Hello again. This is Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs at Truro University, saying welcome back. Welcome back to another one of our webinars. Now, for those of you who have been with us since 2000, you've attended 24 COVID-19 webinars in which we've talked about every possible aspect of the pandemic. But now it's time to turn our attention to a broader set of topics. So we have reinvented ourselves as a medical magazine of the air, in which we're going to touch upon a variety of topics in our 90 minutes together. We're going to talk about some medical topics that have been in the news that are of concern both to healthcare providers and to those of you who are current or prospective patients or just are interested in what's going on in healthcare and medicine. I have picked an assortment of speakers for you today, right out of the headlines. And we're going to start off with Professor Jamie Mullally of New York Medical College. She's an endocrinologist. And I decided that after they were making jokes at the Oscars about how everybody is on appetite controlling drugs in order to control their appetite and lose weight, that we ought to talk about whether you really can take a pill to lose weight, who can take it, who shouldn't take it, what the side effects are, does it work or not, and I've invited her to talk with us about that. Next up, we're going to have a panel discussion with one of your old friends from our webinars, Dr. Tammy Hendricks from Vallejo, California, Turo's College of Osteopathic Medicine in Vallejo, and Professor Vikas Grover of New York Medical College. And they're going to talk with us about a very, very common problem which vexes parents and grandparents. When someone in the house says, that child isn't using enough words, they're not speaking enough, they're not like their siblings, they're not using sentences, you better talk to the doctor. Well, we're going to talk about that problem and what the issues are related to alleged speech language delay in children. Next, we're going to talk about a problem which is unfortunately very common. I've fallen and I can't get up. What do we need to know about the causes, prevention, and treatment of hip fractures in the elderly? Everyone's worried that mom or grandma is going to fall down and break their hip, and then what's going to happen? We've got Dr. David Wellman from the Department of Orthopedic Surgery at New York Medical College to speak with us about that. And then we've got the Dean of the College of Podiatric Medicine in New York City, New York College of Podiatric Medicine. It's Dean Michael Trapel, and he's going to talk with us about how come Tiger Woods says he's got plantar fasciitis and it's interfering with his golf game. Well, turns out a lot of people have or will get plantar fasciitis, and we might as well have an expert tell us about your aching foot and what can be done about it. So a variety of topics, all snatched from the headlines for us to learn a bit about general medicine today in all its manifold aspects. We hope you enjoy our program. As always, if you have questions for any of our panelists, go ahead and type it in the Q&A box on the bottom of your screen, and we'll get to as many of them as possible in our live Q&A part of the program. For those of you who are looking for continuing medical education credit, you will hear my voice show up intermittently in between our speakers to tell you how to get your CME credit. We hope you enjoy our new program. We hope you enjoy our new format. Welcome to the show, and let's get started with our first speaker.
Hello, everyone. I am Jamie Mullally, an endocrinologist and obesity medicine specialist at Westchester Medical Center. I'd like to thank Dr. Halpern and the organizers for the invitation to speak today. I've titled my talk, Doc, I Can't Lose Weight. Should I Take a Medication? I have no conflicts or disclosures. We'll start with a bit of background about the medical disease of obesity. While in the past, obesity was regarded as a problem of willpower and simply eating too much and not exercising enough, it has now been recognized that obesity is a chronic medical disease caused by a number of factors, including genetics, the environment, and complex neurohormonal pathways regulating appetite and energy expenditure. We're facing an obesity epidemic in the United States and worldwide, with a prevalence of obesity among US adults projected to approach 50% by 2030. It's clear we need effective treatment strategies. Excess weight has been regarded as a matter of vanity in the past, but it's now recognized as a serious medical disease which adversely affects nearly every system in the body. Obesity increases the risk of heart disease, stroke, fatty liver disease, diabetes, and increases the risk of several forms of cancer. Moreover, excess adiposity is even linked to premature death. The good news is there is clear evidence of the benefit of weight loss. Even a relatively modest weight loss of 5% can improve things like hypertension, high cholesterol, diabetes, and osteoarthritis. The bad news is it can be difficult to lose weight and even more difficult to maintain significant weight loss. Here we see data from an older study, but the results have been reproduced time and time again. Individuals were started on diets of either 800 calories or 1200 calories a day, and you can see they lost a significant amount of weight in the first 6 months. But unfortunately, over the next few years, we see on average that they regained all the weight. This is not surprising when we consider the neurohormonal changes with weight loss. As a person loses weight, their fat cell mass decreases, which results in important hormonal changes designed to defend their prior higher weight. We see the hunger hormone ghrelin increases, while hormones signaling fullness like insulin and leptin go down. These hormones signal in the appetite center of the brain, and the result is an increase in hunger and a decrease in energy expenditure, which promotes the regain of the weight. So what can we do about this? Are weight loss medications the solution? You may have seen some headlines about newer weight loss medications gaining popularity recently. We see Elon Musk used a popular weight loss drug to get fit, ripped, and healthy. There was a recent 60 Minutes special on medications like Wegovy and Ozempic. And we see even TikTok, Kim Kardashian, and telehealth companies are fueling the use of these medications. So what are these medications? Ozempic and Wegovy are actually the same drug, semaglutide. Ozempic was approved 5 years ago, actually, for type 2 diabetes, whereas Wegovy was FDA approved in 2021 for obesity. Semaglutide is a GLP-1 receptor agonist. So what does that mean? It means it mimics a hormone called GLP-1, which is secreted by the small intestine after eating. GLP-1 signals in the brain to promote satiety and reduce your appetite, and it also signals in the insulin to help with insulin secretion, so helps individuals with diabetes as well. Of note, this class of drugs was actually first approved in the early 2000s for diabetes. And there's even another agent called Saxenda or liraglutide that was FDA approved for obesity back in 2014 as well. So how do you take semaglutide? So both Ozempic and Wegovy are both once a week injectable medications. They come in slightly different pen devices, but both use a very small needle, and you can inject yourself at home under the skin. And the dose of the medication increases gradually over time to minimize any potential side effects. And you may ask, how much weight would I expect to lose on this medication? So this is data for the use of Wegovy, dose of semaglutide in adults with overweight and obesity. And we see by 68 weeks, individuals on the Wegovy lost about 15% more than those treated with the placebo medication. This amounts to about 35 pounds of weight loss with the average starting weight of 232 pounds. We can also look at what percent of individuals achieve a various percent weight losses. We see over 90% of individuals achieve that clinically significant 5% weight loss, and over half achieved at least a 15% weight loss, and over a third achieved over a 20% weight loss. This degree of weight loss had previously not been seen with anti-obesity medications and is approaching bariatric surgeries like the sleeve gastrectomy. The other drug you may have heard about recently is called tirzepatide, or its brand name Mounjaro. We see headlines describing an unprecedented weight loss, and the New York Times reporting more than 50 pounds weight loss, which may be an alternative to bariatric surgery. So what is tirzepatide? It's similar to semaglutide in that it's also a once-weekly injectable medication containing that GLP-1-like hormone, but it also contains a second hormone called GIP, which is also important for the regulation of energy balance. Tirzepatide was FDA approved for type 2 diabetes just in 2022, and of note is not yet FDA approved for obesity, although it is now being considered by the FDA for this indication. In the clinical trials of tirzepatide for obesity, we see individuals treated with the highest dose of tirzepatide lost 22.5% of body weight at 72 weeks, compared with about a 2.4% weight loss with a placebo medication. Additionally, we see over half of participants achieved at least a 20% body weight loss, and over a third of individuals lost over 25% weight loss. So really unprecedented weight loss from a medication. Now, all medications can have side effects, so this is important to consider. With both the semaglutide and the tirzepatide type medications, the most common side effects are gastrointestinal in nature, like nausea being the most common. Diarrhea, constipation, vomiting can also occur. Fatigue, dizziness, and abdominal pain are also reported. In terms of more serious side effects, there may be a slight increased risk of pancreatitis, an increase in heart rate, and a higher risk of gallbladder disease. Acute kidney injury is also rare and appears to be due to dehydration in individuals with more severe nausea and vomiting. Both medications are also contraindicated in individuals with a personal or family history of a rare type of thyroid cancer called medullary thyroid cancer, due to some cases observed in rodents, although it's unclear if this risk is important in humans. It would be remiss of me not to mention that there are other FDA-approved weight loss medications available. None have been as popular as semaglutide or tirzepatide, possibly because the weight loss with these agents is on average less, on the order of 5 to 10%, but they still may be good options for many people. So let's get back to our title. Doc, I can't lose weight. Should I take a medication? We have evidence-based guidelines for determining who should use a weight loss medication. Individuals with the medical disease of obesity, defined as a body mass index over 30, or those with overweight and a body mass index over 27 with serious medical complications like diabetes, high blood pressure, high cholesterol, are also candidates for weight loss medications. Of course, medications need to be used in conjunction with diet and exercise, and I suggest discussing with your doctor or seeing an obesity medicine specialist to determine if and which weight loss medication would be right for you, as the decision must be individualized. In the news, we see celebrities who are normal weight using medications like semaglutide or tirzepatide to lose 5 or 10 pounds, which would not be something I would advocate for. But we're at an exciting point, and there is new hope for helping people lose weight, improve their health, and on a larger scale, combating the obesity epidemic with the medications we've discussed, as well as new agents in the pipeline, which also appear very effective. Thank you for your time, and I look forward to taking your questions in the Q&A section.
Hello again, this is your host, Dr. Edward Halperin. Some of you are veterans of how to get your continuing medical education credit, and some of you may be rookies. Well, whichever you are, here's how to get your continuing medical education credit for today's broadcast. You can get out your cell phone or your other electronic device and send a text message to 828-295-1144. Send the code 21 and in all capitals HOWS, 21 HOWS. Send that message to 828-294-1144. You'll get a text message back telling you how to fill out your satisfaction questionnaire with today's broadcast and how to get your continuing medical education credit. If you don't like that technique, you can type in on your search engine www.eeds.com. When you pull up the website, click on the sign-in button. Once again, enter the code 21 HOWS in capitals, and it will also take you to the sites to fill out your satisfaction questionnaire with today's broadcast and how to get your CME credit. Or you can get out your electronic device that has a QR code reader, aim it at that funny looking checkerboard in the corner of the screen, and it will promptly take you to the website to do the same thing, fill out your satisfaction questionnaire and get your CME credit. May I suggest that you write these instructions down or take a screenshot, grab your cell phone and take a picture of this slide, because this won't go on forever. If you want to get your CME credit, the activity code will expire on Monday, April 3rd at noon. Now, remember, if you have any questions for our panelists, go ahead and type them in the Q&A box on the screen, and we'll get to as many of them as we can during the question and answer period. And let's continue with our broadcast. Hello again, this is your host, Dr. Edward Halperin, and we're here for a panel discussion about an issue which I'm sure has been of concern to many, many parents and grandparents, which is why we put it on our program for today. And that is when somebody in the family says, I don't think this kid is talking enough. I don't think they're using enough words or enough sentences. They're not like their brother or their sister. How do we approach that? So we've got two experts with us from the Touro University and New York Medical College system to speak with us today. And I'm going to have them each introduce themselves to you before we dive into our topic, and we'll do it in alphabetical order. So Professor Grover, can you tell our audience who you are and what you do for a living, please?
Absolutely. My name is Vikas Grover, and I'm an associate professor in the Department of Speech Language Pathology at New York Medical College. Clinically, I work with population 0 to 3 years, birth to 3 in early intervention, and provide speech and language therapy and evaluations, also feeding and swallowing disorders during that period of time. And research-wise, I specialize in speech perception research. So that's a little bit about me.
Thank you. And for those of you who are veterans of the webinars that we've been doing for 3 years, it's your old friend, Dr. Tammy Hendricks, back. I know for lots of you, it didn't matter what your doctor said. You weren't doing anything about COVID unless Marissa Montecalvo or Tammy Hendricks said it was okay. But for those of you who haven't met her before, Dr. Hendricks, please tell the audience who you are and what you do, please.
Thank you so much. I'm Dr. Tammy Hendricks. I'm a pediatrician, professor of pediatrics, and the dean and chief academic officer here at Touro University, California, College of Osteopathic Medicine. Thrilled to be back.
And for those of you looking carefully at the video, that's that bright California sun that's in the corner of her image. She just wanted us to make us feel guilty here on the East Coast. All right, so let's start with Dr. Hendricks. Patient comes in to see you for your 1:30 appointment, and you've been taking care of this child since they brought the child home from the hospital from a normal vaginal delivery, usual milestones, usual childhood illnesses. It's the 3-year-old's visit. And everything looks fine. And then the mother says to you, I don't think this child's talking enough. You know, this is my first child, but I look at my nieces and my nephews or the neighbors' kids, and they're using more words. This one seems to understand everything, you know, shows me where the toys are, but doesn't have much to say. I'm starting to get worried. And if I wasn't worried enough, my mother-in-law is driving me crazy, saying there's something wrong with that kid. You need to talk to the doctor. Dr. Hendricks, what are we supposed to do?
Yes, thank you. That is a very common scenario. And part of it is doing a really thorough assessment to see exactly what the speech development is of that child. So really going through those developmental milestones, reassuring the parents that when we're talking about milestones, they all have a pretty large spectrum of what's considered normal. We have our cutoffs at which we think, okay, this is probably a time when we should do a little bit further investigation. But there's a wide range of normal. So there may be some 3-year-olds that are speaking in full sentences already. There may be other 3-year-olds who are just putting 3 or 4 words together. And anything in between those two scenarios could be completely normal. In terms of speech delay, it's pretty common. We see anywhere from 10 to 20% of toddlers do have some form of speech delay. So once again, reassuring the parents that that isn't necessarily an unusual finding if it does turn out that they do have a little bit of a delay, and letting them know what we can do about it. You know, I think some of my first pieces of advice, which hopefully would happen even before the 3-year-old visit, but just to encourage the parents to talk to the child. The more words that a child hears, the faster they tend to pick up and learn the language. So narrating the day as they're spending time with the child, reading books to children really helps to develop that early literacy and that language development. And then, of course, encouraging the child to use their words. So if they're mainly communicating using hand gestures by pointing out, encouraging them to say the words of what they're pointing out.
Let's say that you decide you are concerned about this child, and Professor Grover, your phone rings and there's a pleasant pediatrician on the line trying to refer a child to you for assessment. Walk us through how a speech pathologist approaches a child with this chief complaint. What would parents expect to happen, and what would you be looking for, and what are the common interventions?
So thank you for the question. And I think I would agree with Dr. Hendricks there that, you know, a thorough evaluation first starts with screening, which probably the pediatrician also does. And then when they make the referral, I mean, we are interested in knowing what are the real concerns of the family first. I mean, why are they worried? What makes them concerned? With specific examples. For example, people can say, oh, it doesn't talk as much as the other kid talks. I mean, that's one way of putting it, but we want to know a little more than that. So we will definitely start by taking some background history, some concerns in specific with examples, different contexts, different situation. How does the child communicate with the parent? How does the child communicate his or her wants and needs? What are the preferred methods? How much time the parent is spending? And then we go into the background history of, you know, birth history, medical history, developmental history, and speech and language history, family history of any speech and language delays or concerns there, social history. If the child is going to a play group, how does the child play there? Play history, child's interaction with other kids. So starting from there, we design what is needed then. Our typical evaluation can use a standardized test or tests or informal assessments. Sometimes we don't use standardized tests because they don't give us all the information. We use criterion reference tests, which are not based on normative data, based on what the child can do. Also, we use something called as dynamic assessment when we work with children to see if we are showing the child something or teaching the child something. Is the child able to showing learning at that time? And if yes, what kind of support helped the child the most? So it's like test, teach, and retest. So we use a lot of methods to evaluate and assess children at that age, because that's a developmental, I mean, they are developing speech and language skills, and it's not an easy thing to assess, because you are not only assessing the expression, you are also assessing the comprehension, the understanding of the language, which can be hard to assess. So I don't think it's a very quick assessment. I think it takes time to do a thorough assessment, and uses many domains: play, cognitive, social, and then language has different domains to be assessed. So that's how we go about it.
Let me ask both of you, and I think I'll start with Dr. Grover and then we'll go to Dr. Hendricks. Have the rules changed because of the pandemic? Because the children were not going to nursery school, were not in daycare, were not sent off to playgroup. Many of them are simply home with mommy and daddy or with siblings. Has this affected what we think is normal or abnormal about speech development in children? Let's start with Professor Grover.
So I think I've been reading a lot of research that's coming out, and people are investigating, and now is the time when the results should be coming out from those studies. But I think people have been talking about monitoring the effects of, say, wearing masks, and what impact does that create? Or, for example, not going to a social setting for children to get to play with other kids of the same age. But another aspect that people have been talking, and I'm talking from experience because one of my friends recently was telling me that she never thought she'll get so much time to spend with her 1-year-old daughter that she got. And that was a great opportunity for her to connect with her daughter. But she missed out on letting her daughter go to play school. So I think it'll be important to keep an eye on how those research studies are showing if there is an impact. But I'm sure it's not an easy study to conduct or studies to conduct, because there are so many factors, including mask, including social domains. So how children are picking up language will be, will be waiting for some results. But so far, people have not said that that all the rules have changed. That's something I can say.
Dr. Hendricks.
Yeah, I agree with Professor Grover. There has been a lot of concern, especially early in the pandemic. There was a lot of concern about mask wearing and what that would do for those really young children who were watching their parents' faces or watching other adults' faces, to be able to pick up more of that expression. As we know, so much of language, so much of communication isn't just the words that we're saying, but also the expressions that we're using on our faces. And a lot of that is covered with a mask. As far as I have seen, there haven't been any conclusive studies that have shown that there has been a broad increase in language delay or language development due to the pandemic. We certainly haven't changed the developmental milestones that we use yet at this time. And I think the bigger concerns may be more associated with some of those social skills and social development, because we certainly saw as daycares shut down or as preschools shut down, those children were spending more time at home just with their immediate families and less time interacting with other children of their own age. And we've seen, even as we've progressed in the pandemic and things have opened up a little bit, there are a number of families who still don't have the opportunity to be able to put their kids back into daycare. And so those children are still missing out on those opportunities. And so I think we'll see not necessarily more language delays, but possibly some delays of those social development, those social skills that we would see them pick up in those early exposures.
Thank you. Well, as typical, the time has flown by, but let's wrap this up with what we would say in the game show world is the lightning round. A quick question. for your quick response. And we'll start with Dr. Hendricks and then go to Professor Grover. My kid has been home during the pandemic watching cartoon after cartoon, and they think the way to speak the English language is like Peppa Pig or like Bluey. I'm worried my child is going to end up with a British or an Australian accent from watching these cartoons. Is this a serious concern about the effect of cartoons on language development in children, Tammy?
No, although it's a humorous concern. I think it would be very cute if we suddenly had a bunch of toddlers here in the States who had cute little British accents. However, the impact of screen time on a developing brain is huge, and their ability to maintain focus. There are so many more negative impacts of large amounts of screen time that go well beyond any concerns for possible impacts on speech development.
And I agree with Dr. Hendricks. Screen time, yes, I'm concerned about that, but I think I'm coming from a different perspective about that. So, when kids are watching a show or something, that gives parents an opportunity to actually build language with them. They can talk about the show. They can expand their vocabulary. They can extend their phrases. They can introduce new vocabulary related to the story. It necessarily doesn't have to be only during the cartoon time, but at a separate time, they can talk about the story, or they can say, okay, let's act it out. Let's play with your sisters and brothers and create a scene. So it's an opportunity for parents and siblings or family members to actually support the language development.
It's putting a good spin on. I'll have to admit it, since we always have to disclose conflicts of interest. I have a particular fondness for Grandpa Pig on Peppa Pig, because like me, he's a stamp collector. So I always pay very close attention after Mummy and Daddy Pig to Grandpa Pig, because he reminds me of me. Well, I want to thank our two guests for joining us today for a very enlightening discussion. As always, if you have a question for either of our panelists or the other speakers, you type it into the Q&A box on your screen. We'll get to as many of them as possible when Dr. Kadish moderates the question and answer period. And watch for our announcements about how to get your CME credit during the course of today's program. And now let's continue with our webinar. Hello again, this is your host, Dr. Edward Halpern. I want to talk with you for a moment about giving back to New York Medical College. Programs and research projects like the ones that you're hearing about today clearly require time, effort, and funds. But we never charge for CME credit for those of you getting CME credit from these programs, and we never charge indeed for these programs at all. They're all provided at no charge. We hope some of you will consider making a donation to the college to help offset our costs. Great things are happening at New York Medical College. We hope you'll be a part of it. We hope you'll consider visiting our website, www.nymc.edu/give. For more information about how to make a donation in support of these webinars. We offer multiple choices for a donation. For those of you who don't want to do it online, we answer the telephone. You can call 914-594-2720, and someone from the college fundraising office will be happy to take the credit card information over the phone. For those of you who believe in pen and ink and checkbooks, a check can be made out to New York Medical College. Please write webinar on the memo line of your check so we know to whence it should be directed for your donation. Put it in an envelope and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. However you do it, thank you for thinking of us and for supporting these webinars. Stay safe and healthy. If you have a question for any of our panelists, type it in the Q&A box and we'll get to as many of them as possible during the Q&A part of our program. And let's get back to our program.
Hello, everyone. I'm David Wellman. I'm the Medical Director of Orthopedic Trauma at Westchester Medical Center. And I'm going to be speaking to you today about the causes, prevention, and treatment of fragility hip fractures in the elderly. I do not have any disclosures related to this talk. Over the next 10 minutes, we're going to be talking about why bones weaken over time, what can be done to prevent bone loss, what can be done to treat bone loss, and then how do we manage the fragility fractures that happen despite these management choices. We're going to follow this case throughout the lecture. This is a 79-year-old male with mild dementia, current smoker, who suffered a low-energy fall, sustaining the femoral neck fracture that you see right here, traversing the neck of the femur inside the hip joint. So why do our bones weaken over time, and why do we get fragility fractures as we age? Bone mineral density actually begins to decline after the age of 30. And this is because bone is a living tissue that's continuously remodeling, meaning calcium is getting deposited on the bones and being harvested from the bones for use around the body. And so this calcium store is constantly in flux. And the way that it fluctuates is it responds to certain factors in the bloodstream that tell it what to do. And as we age, those factors change over time. And a great example of that is menopause, where the body sees decreased estrogen levels that ultimately ramps up the activity of osteoclasts, thereby leading to bone resorption and weaker bones. Osteoporosis, which we'll be talking about throughout this case, is actually a medical diagnosis and a definition. It's a bone disease that occurs when the body loses too much bone, makes too little bone, or both. And the way to diagnose this is through a DEXA scan, which looks at bone mineral density, typically in comparison to healthy young women, and you're graded as to how many standard deviations you are below that of a young, healthy person. And so once you're 2.5 standard deviations of density below that of a young, healthy person, you get a diagnosis of osteoporosis. The other way to get a diagnosis of osteoporosis is to suffer a low energy fall, like the gentleman that we met at the beginning of this talk, with a fracture of the hip or spine, regardless of your bone mineral density. You get a diagnosis of osteoporosis just from that alone. I think the effect that this has on society is pretty vast. 1/3 of women and 1/5 of men over the age of 50 will experience an osteoporosis-related fracture over their lifetimes. This is a giant problem from a society standpoint. The factors in your body that manage bone remodeling, I've got blown up on the screen here, and you see some of the heavy talking points from general medicine lectures, like calcium, vitamin D, parathyroid hormone. All of the things that you see listed here are in a balance in the body to manage the bone stock and the calcium levels in your blood. Looking at numbers, the hip, forearm, and vertebral bodies of the spine are the most common areas to get fragility fractures. We anticipate 9 million osteoporotic fractures occurring worldwide yearly, and these rates are expected to rise 200% in women and 300% in men by 2050 compared to 1990. So that's over 60 years. The numbers of fractures are increasing dramatically. Risk factors for osteoporosis are essentially listed on the screen. What you'll see is some things that are not modifiable, like race, age. Some things are modifiable, like alcoholism, smoking, poor diet. And as practitioners and doctors, one of our focuses is to find modifiable risk factors early. And a good example of that is exercise and diet, and teach patients at a younger age to begin good habits to hopefully preserve the bone mineral density that they're losing starting at the age of 30. In terms of prevention, there are several preventative measures that we'll talk about during this talk, but ultimately only 17% of patients eligible for medical treatment for osteoporosis ultimately get it. Men are disproportionately ignored, mostly because when you think osteoporosis, the first thing that pops in your mind isn't necessarily the male sex. Again, our goals as practitioners are to address these modifiable risk factors early, promoting exercise, diets high in calcium and vitamin D, smoking cessation, and alcohol reduction beginning at an early age to prevent the ultimate effects on bone. Obviously, as we get older, less falls equals less fractures. Two things that really help decrease falls and fractures in the elderly are balance and muscle strengthening, as well as moderate to high intensity exercise. And in a patient that exercises with moderate to high intensity, greater than 120 minutes per week, you do see less fragility fractures. Ultimately, from the medical standpoints, one of the main tools that we have in our kit to prevent fractures is medication. And the way that we assess if patients are eligible for medication for osteoporosis fracture is typically through a FRAX assessment. It's a tool that you can download very easily that'll help grade your patients and their risk factors for developing fragility fractures. Now, ultimately, as a profession, we do not do a very good job of actually getting our patients the medication that they probably need. Only 17% of patients that are eligible for treatment ultimately get it, like we talked about before. And what's interesting is after a hip fracture, meaning after someone has clearly demonstrated that they're prone to fragility fractures, only 15% of these patients ultimately receive consultation for medical treatment of the osteoporosis that they just proved that they have. What are the effects of medical management of osteoporosis? One fracture prevented for every 10 patients treated. And so a giant missed opportunity on a population basis for decreasing this very, very prevalent problem. What medications are out there? Falls into three basic categories. We've got calcitonin, anti-resorptive medications, and anabolic medications. Calcitonin, I'm not going to talk about because its effect once osteoporosis is taken over is not seemingly as dramatic as the other groups. Anti-resorptive medications work by decreasing the activity of the osteoclasts, the cells that actually harvest calcium from bone. Anabolic medications work through the parathyroid hormone system to augment the body's ability to make bone. So two different routes to get to higher bone mineral density. Both of them have their own risks. The anti-resorptive medications have been linked to jaw necrosis and atypical femur fractures. The anabolic medications are theoretically associated with osteosarcoma, but this is in animal models and has not been proven in humans. But if you look at the overall effect of these medications, one fracture prevented for every 10 patients, these risks and negative side effects of these meds happen on a much, much, much lower scale. And so as a population, these medications do have an overall significant benefit. Back to the case. And so let's say all of this has failed. We did not treat this man's osteoporosis, and now he presents with this fracture. Our goals from a surgical standpoint, once the fractures have occurred, is to mobilize patients as soon as possible. Typically at this institution, we'd like to get our hip fracture patients back to the operating room within 24 or 48 hours at the latest from their injury, because time to surgery is directly related to mortality and morbidity. Once we operate, obviously the goal is to mobilize the patient. So the surgery has to be done in a fashion that allows for immediate weight bearing and mobilization. So in this 79-year-old male with mild dementia, current smoker, because his fracture is in this location on the femoral neck, actually fixing his fracture likely won't result in a good outcome because the blood supply to the ball of the hip has been compromised by the fracture. Blood flow into the femoral head flows retrograde. And so this fracture essentially cuts blood supply off from the ball. And so the treatment for that is a hip replacement, especially in older folks with potentially some dementia, maybe movement disorders. We need to do these hip replacements in a style that doesn't require any weight-bearing restrictions and doesn't require any positioning precautions, meaning that once we finish the surgery, we can essentially let the patient ambulate and mobilize as tolerated. And that's what we did for this gentleman. The other style of hip fracture that happens in the elderly is a pertrochanteric fracture. And this is a fracture that's around the trochanters of the hip. And you'll see on this patient's left side, the fracture is much lower than it was in the femoral neck from the last case. The femoral neck patient, the fracture was up here. Here it's a little bit distal in the bone. In this case, the blood supply is preserved to the proximal segment. And so fixing these fractures is possible. And typically what we do for cases like this is we insert a device into the medullary space of the bone that again allows for immediate weight bearing and no movement precautions. And in both of these patients, they have essentially identified themselves as having fragility fractures, and we should be targeting them in the hospital to get them on the proper medications. And so at the end of this talk, just want to make sure that we achieved our goals. We've talked about why bones weaken over time and the factors that are involved in making that happen. We've talked about what we can do to prevent bone loss, and that's activity, diet, restricting cigarettes and alcohol, as well as the medications that can prevent bone loss. We've talked about treatments, and we've also discussed our general overall concepts in managing the resulting fractures in the elderly, which involve essentially early mobilization and immediate weight bearing so these people can get out of bed and get back to life. Thank you for your time.
Hello again, this is your host, Dr. Edward Halpern. Some of you are veterans of how to get your continuing medical education credit, and some of you may be rookies. Well, whichever you are, here's how to get your continuing medical education credit for today's broadcast. You can get out your cell phone or your other electronic device and send a text message to 828-295-1144. Send the code 21 and in all capitals HOWS, 21 HOWS. Send that message to 828-294-1144. You'll get a text message back telling you how to fill out your satisfaction questionnaire with today's broadcast and how to get your continuing medical education credit. If you don't like that technique, you can type in on your search engine www.eeds.com. When you pull up the website, click on the sign-in button. Once again, enter the code 21 HOWS in capitals, and it will also take you to the sites to fill out your satisfaction questionnaire with today's broadcast and how to get your CME credit. Or you can get out your electronic device that has a QR code reader, aim it at that funny looking checkerboard in the corner of the screen, and it will promptly take you to the website to do the same thing, fill out your satisfaction questionnaire and get your CME credit. May I suggest that you write these instructions down or take a screenshot, grab your cell phone and take a picture of this slide, because this won't go on forever. If you want to get your CME credit, the activity code will expire on Monday, April 3rd at noon. Now, remember, if you have any questions for our panelists, go ahead and type them in the Q&A box on the screen, and we'll get to as many of them as we can during the question and answer period. And let's continue with our broadcast.
Good day. My name is Mike Treppel. I am the Vice President for Academic Affairs and Dean at the New York College of Podiatric Medicine, one of the newest members of the Toro family, and I'm delighted to be here today to give this clinically related talk on plantar fasciitis. I have no disclosures pertinent to this talk to make. And before we can talk about plantar fasciitis, we need to briefly review the role of the plantar fascia and its role in the windlass mechanism, which helps us to propel forward during gait. A tight plantar fascia designed to maintain the arch is dependent upon a stable osseous structure. When that stable osseous structure breaks down, undue stress is placed within the plantar fascia, and all sorts of pathology then ensues. Plantar fasciitis is a term that's commonly used. Heel pain is probably the #1 presenting complaint in a foot doctor's office. Histologic studies have shown that in many cases there is an absence of acute inflammatory cells, and in fact a degeneration of the plantar fascia. So you can use the term fasciosis in lieu of fasciitis and be correct from a histopathological extent. Plantar fasciitis becomes chronic in about 5 to 10% of patients, and it is not necessarily associated with a heel spur. although many patients will have a concomitant heel spur. And over 90% of the cases will resolve with conservative therapy. Anatomically, the plantar fascia is seen on the left-hand side there as a band. It is confluent with the Achilles tendon, which wraps around the back of the heel. And when that plantar fascia becomes subject to increased tension or strain, it will then become inflamed or degenerate in the area of predominantly the medial calcaneal tubercle. As I said, many of these will be associated with an inferior calcaneal spur, as is noted on the X-ray seen on the top. But also we see patients with multiple inferior spurs that emanate from the various origins of the 4 layers of the plantar intrinsic muscles. The pathomechanics which occurs in the majority of cases is that when the foot goes from non-weight bearing to weight bearing, the osseous structure collapses, putting the excessive stress within the plantar fascia. In the middle row of slides, you can see on the left-hand side a heel that's in subtalar neutral position that upon weight bearing excessively everts, again elongating the arch. On the right-hand side there, you can see a forefoot deformity referred to as forefoot varus that compensates by pronating through the mid-tarsal joint, likewise putting a excessive tension within the plantar fascia. Also important in this is the high incidence of equinus or tightness within the posterior heel cord. As I said before, the Achilles wraps around the back of the calcaneus, becomes confluent with the plantar fascia. Increased tightness, tension, or shortness within the posterior musculature results in compensatory pronation and excessive stress put in the plantar fascia. You can see in the bottom X-ray a posterior spur which runs into the insertion of the Achilles, looping around the back of the calcaneus, and then into the plantar fascia. You can see how that pathologic force does it. We can measure this by doing computerized gait analysis. This is done with sensors placed in the patient's shoe and ask them to walk a series of steps. You can see on the left-hand side increased loading within the heel area and an absence of loading underneath the first metatarsal, indicative of increased plantar fascia stress. Plantar fasciitis symptoms, predominantly pain on standing, particularly after periods of inactivity. The textbook presentation of this is patient complaining about pain arising in the morning. The pain generally subsides with a return to activity. It can be related to footwear, be worse in flat shoes. Pain can radiate to the arch or the toes. In the later stages, may progress throughout the day. Differential diagnosis is important. In children, it could be calcaneal fasciitis. In adults, seronegative arthritis, such as psoriatic arthritis depicted in the upper right-hand X-ray. Entrapment of Baxter's nerve, or the lateral plantar nerve, can occur, as you see in the lower left-hand slide. There's a branch of the lateral calcaneal nerve that is frequently entrapped. That can be diagnosed with an MRI showing atrophy of the abductor digiti minimi. The next slide over shows a schwannoma involving the posterior tibial nerve, resulting in tarsal tunnel syndrome, replicating plantar heel pain. The next one over there is a calcaneal stress fracture in a weekend warrior athlete. And the last slide on the right was a very unfortunate situation of a 41-year-old radiologist who was initially diagnosed with plantar fasciitis. That was the initial presenting X-ray. He was lost to treatment for a number of months, probably close to a year, ended up in different areas, and ultimately was diagnosed with a chondrosarcoma of the heel. And you can see the increased density down at the inferior surface was the early signs of the chondrosarcoma. He unfortunately at that point already had pulmonary metastasis and succumbed to his illness several months later. The evaluation of this is kind of classic textbook, pain on palpation of the medial calcaneal tubercle, pain exacerbated on dorsiflexion of the arch, which puts stress within the plantar fascia. Imaging, traditional X-rays are done predominantly not to see the presence or absence of a spur, but to rule out any associated conditions. MRI can be done to demonstrate other conditions such as a complete tear of the plantar fascia. Ultrasonography also is useful in certain cases to look for plantar fascial tears. Bone scans, technetium bone scans are rarely indicated in today's day and age. The treatment is really twofold. Number one is we need to treat mechanically the cause, and two, we need to treat the pain or the anti-inflammatory, and neither is done in isolation. In terms of treating the inflammation associated with calcaneal spur, ice, rest, local injection of a local anesthetic and steroid, oral or topical NSAIDs. Some people choose to do an ultrasound guided injection. I do it on occasion, but I think a good knowledge of the local anatomy precludes the use of ultrasound. We can inject where we need to be, usually quite accurately, and using the ultrasound increases the time and also the expense of the procedure and isn't always necessary. In terms of treating the etiology, initially what we want to do is rest the plantar fascia. That can be done by appropriate taping of the arch, utilization of prefab off-the-shelf arch supports. Night splints are commonly referred to, but I find that patients find them uncomfortable and rarely will be consistent with wearing them. Plantar fascial stretching exercises, as seen on the bottom right, can be useful if done judiciously and frequently and properly. The key thing here, where you have a mechanical problem, which is the majority of cases, is to control the foot biomechanically with a custom foot orthosis. Generally, we want to have this with adequate rear foot and forefoot posting to control those actions of the foot associated with a deep heel cut, and generally a first ray cutout, which will help plantarflex the first metatarsal and decrease the stress within the plantar fascia. We can see here the effect of the loading of the foot with and without an orthosis. On the left-hand side there, we see the left and the right calcaneus, which show abnormal loading. For the left side, we see prolonged stretching within the plantar arch and aberrant pressure underneath the right calcaneus, which is due to a rocking motion. With the same test done with a patient with a custom orthosis, we can see more normal loading curves of the foot. Other options for heel pain where traditional conservative management is not effective would be extracorporeal shockwave therapy. We can use high energy and low energy, autologous platelet concentrate APC. Really, the literature doesn't totally support this. It is really something that can be done with minimal risk to the patient. It probably has more hype than it does efficacy in the treatment of this. And lastly, radiofrequency coblation in really recalcitrant cases. But once again, the literature is not really supportive of this means of therapy. In cases where everything fails, surgical option is available. I probably see hundreds, if not 1,000 cases of this each year. If I operate on 1 or 2 a year, that is a lot. We have the option of doing an open plantar fasciotomy with or without resection of the spur. And now we can also do it endoscopically, utilizing a tiny little blade under direct visualization with an endoscope. So that is an overview from a clinical perspective of plantar fasciitis, what it entails, some of the diagnostic keys that can help you arrive at the diagnosis, and the common treatment modalities that are utilized in the management of it. It has been a pleasure to participate in this, and I look forward to answering any questions anyone might have. Thank you very much.
Hi, I'm Dr. Alan Kadish, president of New York Medical College and TU University, and I'm here to moderate the question and answer session. The first group of questions is for Professors Grover and Hendricks. If you could join me, I will get a couple of questions for you. So the first question is, how do you help children catch up from speech delay? What can speech therapy do? Perhaps Dr. Grover can take care of that first.
Hi, yeah, that's a great question. Generally, I always suggest parents to communicate with their kid as much as they can. I mean, they're talking to the child, they're engaging the child in regular conversations, asking questions, modeling their speech and language, and developing on where the child is. Meeting the child where the child is very important. So suppose the child is using single words and you want the child to combine words, so model 2-word combinations, or expand their words, single words into 2 words, 2 words into 3 words. Reading books is another way that you can really support your child. But I think engaging with the child and engaging the child in interactive communication will be key in this suggestion. Thank you.
So a follow-up question for that, 2 follow-up questions really for Dr. Grover and then Dr. Hendricks as well. Perhaps you can weigh in. There are 2 questions that really relate to when is it appropriate to refer a child for speech therapy. Let's say they're just developing language. They're a year and a half or 2 years old, and they seem to be behind their peers. What's the threshold for referral? In other words, at what age, at what level of speech development would you say is the time to refer?
Each child is unique in that way. And I personally feel that milestones are one part of the equation, but generally understanding the whole child is really important. For example, if the child is, say, 2 years or between 2 to 3 years, and the child is only using a few single words and no multi-word utterances, not asking questions, not showing any ways to ask the listener to request something from a listener or from the parent, I would definitely refer the child for an evaluation, as opposed to if a child is 12-month-old and developing some single words and showing some communicative intent, pointing, using some gestures, then I would say, okay, we can wait, and this child is showing some signs of emerging speech and language skills. So it really depends on the child and the communication system. So I would trust the parents in information and ask them questions about where the child's communication is and how do they see the child is communicating. If the child is communicating and they are still concerned about the child's development at the age of 2 to 3, sure, an evaluation can help them understand where the child is.
Dr. Hendricks, when do you refer? What criteria do you use?
Yeah, that's a great question. And I agree with Dr. Grover. A lot of it is taking the entire context of the child and their developmental abilities into account. We certainly, in pediatrics, we do rely on the developmental milestones. So that's something that the parents can easily look up on the American Academy of Pediatrics website or even the CDC website to see what language milestones we expect at certain ages, realizing that it is a full spectrum. Some kids will be doing a lot more and some kids will be doing a little bit less, all within the normal ranges. But if a child is really falling behind on the expected milestones, that's certainly a time when we start to talk about referring them on. And I'll also say I tend to refer earlier rather than later, because it's certainly not going to hurt them to get some speech therapy, to get some additional assistance if they need it.
Great, thank you. So a follow-up question to that. A couple of the questioners were concerned about how you distinguish speech delay that can be taken care of with speech therapy from more severe organic brain problems that really represent structural abnormalities of the brain rather than functional abnormalities. So when would you evaluate a child for that? And after speech therapy, after some point in speech therapy, if you aren't getting optimal results, would you then refer a patient to a neurodevelopmental specialist or request some imaging? So what's the, first of all, how do you tell the difference? And then what's the threshold for doing further evaluation?
Yeah, absolutely. I can definitely give the pediatrician perspective, and then perhaps Dr. Grover can give the speech pathologist perspective. Once again, looking at the child to see what other areas that they may be delayed in. So what other milestones they may be delayed in. Do they have any motor delay? Does it seem like they have some processing delay, some other issues? If they have more than one delay, then that is certainly a time when I will not only refer them to speech therapy, as well as potentially physical therapy or occupational therapy, depending on what else they have going on, but also start to do a little bit further investigation to see if there may be a more organic cause or something that could be contributing to both. And then in relation to the second part of the question, if a child's been in speech therapy and receiving good, consistent speech therapy for 6 months and we're not seeing improvement, that would definitely be a time to start investigating to see if there's more that we need to be looking into.
Great,
Thank you.
Dr. Grover.
I completely agree with Dr. Hendricks. And, when we look at a child and when we hear the parents' concerns, the parents are concerned. Say recently, I had a parent who talked about whether this is a delay or this is something called as childhood apraxia of speech. Somebody had mentioned it to them. And, one way of looking at that is to understand what's going on behind the problem. For example, in childhood apraxia of speech, you will see certain things like a child is finding it difficult to show the movements required to complete that word from one speech sound to another. And that movement is important. They'll show groping, they'll show inconsistent errors or in vowels or consonants, and having difficulty to form that planning movement or programming movement, right? So we will know what kind of evaluation to do and how to, as opposed to a child who's using less number of words, but not showing other things that will help us understand whether we should evaluate for childhood apraxia of speech or not. The second part of the question is—
If I could just interrupt you for a second, perhaps for the audience, you could define childhood apraxia of speech.
So it's an uncommon speech disorder in which a child has difficulty making accurate movements while speaking. So they are trying to grope for the sound, trying to reach for the sound, but it is actually the difficulty that that causes a challenge for children to plan and program the movement. For example, if somebody has to say the word bat and to move from that initial sound to the second sound or the third sound in the word, the planning required is affected. So very specific, and the transition between the sounds are affected. So that's where childhood apraxia of speech comes.
Got it.
Thank you.
Dr. Hendricks, anything you want to add?
No, I think Dr. Grover covered it well. Thank you so much for the question.
So I'll ask you a final question, which I think there's probably no answer to, but certainly interested to hear your perspectives. There were some issues brought up about screen time. And I know that you both viewed screen time a little bit differently, but how much is too much screen time?
If you were to ask the American Academy of Pediatrics, they have a pretty strict limit of 2 hours, no more than 2 hours total screen time per day. As the mom—
Does that include Zooms?
Yes, we all well exceed the recommended dosage of screen time a day. As a mom of a 9-year-old and an 11-year-old, I can say it is very hard to get your kids to limit them just to 2 hours a day. But that is the recommendation by the experts.
Dr. Grover, do you have a different view from a speech point of view?
I have no reason to go against what Dr. Hendricks has said. However, I would add one comment to her comment that, sometime, for example, if the age is important, right? So if a child is, say, around 12 to 18 months or 15 to 18 months or 24 months, we really want to value that language development period. So that interactive communication with the child is so important that as less as screen time will be better for the child. So I just wanted to add that. So will I put a number to it, 30 minutes, 45 minutes? I cannot put a number, but I can say that I would encourage as much as interactive communication time with the family members and with the children.
Particularly during that speech development period is what you're saying.
Yes.
Great.
Thank you so much for the question.
All right, I think we've tired the two of you out, and so I'll say thank you. If some more questions come up later, please stick with us. We have a number of questions for Dr. Mullally. So if I could ask her to join us, say goodbye to Dr. Grover and Dr. Hendricks. Do you have any advice as to how to be a supportive, significant other for someone who's on a weight loss journey?
It's a great question, and it's very difficult, as anyone who ever has been on a diet or tried to lose weight, it's difficult to do and to adhere to long term, and it's very important to have support at home. So I would say some things you could do, have healthy foods around. If you know your partner can't resist Oreos, don't keep the Oreos in the house. Don't try to tempt or sabotage their efforts with weaknesses. And a lot of our social activities center around food. I think something else that we can do is find activities that keep us all active. So a family walk on the weekends, or finding a sport that you like to play together, something that keeps you busy, keeps you active, is burning calories, and then just supporting the time that your spouse needs to go to appointments, to see a dietitian regularly, or be in a behavioral change program really predicts long-term success with weight loss as well.
Thank you. So a quick follow-up question to that. If you had to rate the relative importance of physical activity versus calorie restriction in weight loss, you mentioned physical activity. How would you balance those two? How important is activity, and how important? Obviously, they're both important, but in terms of your experience and people who've been successful at weight loss, which of those two is more important, and how do you balance them?
So for weight loss, absolutely, diet is the most important component. You really cannot outrun a bad diet, as the phrase goes. So about 80 to 90% of the weight loss is the result of the diet. The physical activity may account for about 10 or 20% of weight loss. That being said, physical activity is very important and has numerous health benefits. But I would say in the active weight loss phases, the dietary changes and calorie restriction really is what's most important.
Thank you. There was a question about the guidelines based on BMI. Is BMI really the best measurement, or is it just because it's easily available, that's what people focus on?
Exactly, a great question. So there's definitely limitations of BMI. We use BMI in clinical practice and to apply our guidelines for treatment of obesity because it's readily available. It's just the ratio of weight and height. It does not account for one's muscle mass, one's fat mass, the distribution of fat mass. So this is a big limitation of BMI. You can have a bodybuilder who would be considered obese by their body mass index. And clearly that does not reflect their health status. So other surrogates we can use, I like to use waist circumference. Waist circumference has independent prediction of cardiovascular and metabolic risk. So waist circumference is something that's easy to measure and follow over time. And then we can actually calculate body composition with bioimpedance scales in the office in less than a minute. Someone just stands on a scale and we're able to calculate their body composition. So I think that is the future, as this technology is more inexpensive and more readily available. I think we will move away from body mass index and use more sophisticated measures due to the limitations of the BMI. Thank you for that question.
Sure. So we have a question from a pre-diabetic whose physician prescribed Ozempic, but whose insurance company said that you have to take metformin first. Presumably that's for diabetes alone indication. Are insurance companies paying for weight loss drugs? And is there a way to appeal because of the demonstrated improvement in health outcomes from weight loss?
Yes, so this is the most frustrating part, I would say, of prescribing anti-obesity medications. And I'm having conversations with my patients all day long, about what might be covered. If it's not covered, what we'll be doing. So what usually happens, the doctor sends a prescription Often the doctor will send the Ozempic because they know Medicare or Medicaid will not cover the Wegovy. They do not cover any weight loss medicines. So other medicines FDA approved for diabetes are used off-label to treat obesity. It depends on the insurer. Some insurers will allow the use of a diabetes medicine, even if the patient does not have diabetes. Other insurance companies require a prior authorization and they ask the physician, does the patient have type 2 diabetes? If the answer is no, they exclude coverage of that drug, and that's their policy, and there's really nothing that can be done. So I think it's complicated. Every insurance company is different, but usually the first step is sending it to the pharmacy, doing the prior auth, or calling your insurance and asking them if it's covered and if there's a prior authorization required. But it's not straightforward, and it's even me doing it every day. It's hard to know what will be covered by what plan.
Thank you. Speaking of you doing it every day, one of the questioners wants to know whether they need to be referred to you before starting on Ozempic, or whether an internist or family medicine physician can responsibly do it.
Yeah, so I think one of the big barriers to treating obesity is a lack of providers that are comfortable prescribing medications for patients. About 2% of eligible patients actually receive anti-obesity medication. So what I would recommend is starting with your primary care provider, having a discussion with them about your weight and weight loss goals. And I would ask them if they're comfortable prescribing the medication. If they're not, they can often refer you to somebody who is. Endocrinologists are often trained in obesity and have additional experience, or you can go to the board certification agency, American Board of Obesity Medicine, abom.org, and there's a list of providers nationally. So you could find a provider there that would be very comfortable prescribing these types of medications.
Thank you. So last question. Other countries have tried a tax on sugary drinks, similar to the tax we have on tobacco or alcohol. Do you think that would improve public health, and would you support that?
So I think this question really highlights that obesity is a huge problem, and not one that just medications will solve. We absolutely need public health interventions as well. I think the sugary drink tax has been debated. I think there's some strengths of the sugary beverage tax. I think there's some downsides in that it tends to affect low-income people more. So I'm not sure that it's the solution. I absolutely support, reducing and eliminating sugary beverages. That's one of the first things we talk about with patients. But I think it's a complicated public health issue, and changing our environment one way or another will be important in combating this on a public health scale.
Great, thank you very much.
Thank you for the great questions.
Sure. Next set of questions is for Dr. Wellman.
Hello.
Hey. So the first question is exercise to strengthen bones. What kind of exercise works? Do you have to sprint or run, or are there other kinds of exercise that will help increase bone strength?
No, I think it's important to not say one particular thing is beneficial over another, because everybody has different abilities, right? People are coming into exercise, especially if they're not lifelong exercisers, and you don't want to turn somebody off by setting the standard too high. I think for someone that is nervous about exercising, about the safety of going to like a weightlifting program or something like that, I encourage them to take a class, right? I think it does a couple things. One, it gets you out of the house. Two, your questions can be answered in real time. And honestly, any activity that gets you, weight bearing, putting stress across your skeleton and across the muscle groups are going to lead to better balance, and it's going to decrease your muscle deterioration that happens with being sedentary. And so I wouldn't be restrictive in saying you have to do one thing over another. I think you have to do something, and do something consistently. I think that's the main take home.
And particular weightlifting is fine.
Yeah. Oh yeah. Yeah. The loss of muscle mass that happens with natural aging is a big deal. Yeah, I think that, weakness is one of the reasons that people aren't able to compensate if they trip on a loose carpet or stumble walking down the sidewalk. And muscle mass deterioration is a natural part of aging, and the only way to combat that is by increasing your activity level. And so, yeah, weightlifting not only is okay, it's encouraged.
Speaking of carpets, do you have recommendations for houses of the elderly? Should we avoid carpeting? Are there other things that we should sort of?
Sure. I think the NIH, has a division on aging that actually has a pretty good web page if people want to go to it on what you can do around the house to decrease your chances of falling. And I think they all fall under pretty similar themes if you look across the house. It's getting rid of barriers to walking. And so, throw carpets, clutter around the house, all that should be cleared up. Putting some non-slip tape on stairs, sort of, just at the edge of the step, which is pretty easily found at any hardware store. Making sure handrails are in the appropriate places, and making sure lighting is okay. So making sure you can see, making sure you've got an unimpeded path to getting around your house, and get rid of anything in the way that you could trip over. And so all those decorative throw rugs and things like that, get rid of them.
Okay, last question. You talked about vitamin D supplementation.
Sure.
So do the population studies support vitamin D supplementation? It's a pretty complicated topic, right?
It is. I think if you look at the slide above all the factors that are involved in bone health, I mean, vitamin D is just one small little line. I think vitamin D supplementation in isolation, without any other intervention, doesn't seem to make that much of a difference, but vitamin D in combination with calcium has. And so I would caution against looking at one study that says vitamin D doesn't help and throwing away the entire concept. Vitamin D is a critical part of bone metabolism. I mean, that's it in a sense is how you absorb calcium from the diet. And so vitamin D with calcium has been shown to have a benefit in terms of fracture reduction. So no, please don't read one study that says don't worry about vitamin D and forget about the whole thing. It is a critical component to bone health, and still a recommended supplement along with calcium.
That's great. Thank you so much, Dr. Wellman. Great talk, and hopefully we can reduce the incidence of hip fractures and other fractures in the elderly, because they tend to be devastating when they do happen.
My pleasure. Thank you for having me.
Sure. Last set of questions is for Dr. Treppel. One question is, can you tell us about the relative efficacy of the custom-made orthotics that you talked about versus just going to the store and getting Dr. Scholl's orthotics, or going to one of the running stores and getting one of their custom-made, but not professionally perhaps made, shoe implants?
That's really a great question, and we get asked that frequently by patients and other providers. Well, it depends upon what the nature of the pathology is. If we're talking about your garden variety of plantar fasciitis, many times a prefab device which fits into the shoe and will support the arch and lift the heel will prove efficacious and work. If someone has a more complex deformity, imbalances within the foot, in those cases, an evaluation for a custom-made device may be well indicated. For plantar fasciitis, I generally will start patients out on a prefabricated device for a number of reasons. First one being that you can get it right away. You don't have to wait for a custom-made device to come back in. Number two is the cost associated with a prefab is significantly less than a custom-made one. And number three, for plantar fasciitis, it frequently will work. Nothing is 100%, but in many times, if not most, for this entity, they will be efficacious and work.
It seems as if the incidence of plantar fasciitis is increasing. First question is, would you agree with that?
Yes, in most podiatrist office, I think it's a safe bet to say that the number one presenting complaint is heel pain. So we see it. We are seeing it on a more expansive age range, and in the past it was more middle age, and now we're even seeing younger people with it. And as people are more mobile and more active into older age, where it's not that uncommon to see it in an older individual as well. Yeah. For sure.
Now, so one of the questioners thought that perhaps the change in the quality and way we buy shoes might be responsible as well. Do you think that's true, or is it mostly the increase in physical activity?
Well, there's a number of things into it: increase in physical activity, obesity, weight gain, all play a major role in this. Remember, the foot was evolved not to walk on hard surfaces or floors. The foot evolved to walk on the savanna, in a jungle, and when we walk on hard, flat surfaces, that's the need for shoes. And I've always said that bad shoes are better than no shoes on it. So if the shoe is too small or too big and the foot rocks in it excessively, or it's too tight and causes other problems with the foot, that obviously is no good. But by and large, the heel pain and plantar fasciitis is a function of the mechanics or the pathomechanics of the intrinsic nature of the foot itself. And as a foot or a shoe which will help support the arch and lift the heel minimally will help in many, if not most. And of course, if the cause of the heel pain is other entities, like we mentioned before, then shoe therapy really isn't going to be that much of an impact.
Sure. Last question. A couple of years ago, there was, for runners, a fad to wear these sort of glove type shoes instead of traditional running shoes, sort of hearkening back to your idea that we evolved not to wear shoes. In your experience, has that reduced or increased the incidence of injury or plantar fasciitis?
Yeah, great question. And a lot of that depends upon your foot structure. The shoeless running, as it was called, or the Vibram shoe, which was like 5 fingers, fit like a glove on it, in many cases did cause more injuries. We saw an increase in stress fractures on the foot. A lot of it depended upon the stride that one takes when they run. Toe runners, people who run off their toes, that usually are people who run faster or more brisk. They can do all right with those shoeless people. The more traditional runner who has a heel to toe gait, where you needed to have a little bit more support, those are the patients that we actually did see an increase in running injuries on it. And you don't see that many people coming in with those type shoes as well. And of course, there was the low heel shoe that was, I'm dating myself, but many years ago. And again, they excessively stressed the Achilles tendon. And we saw a fair amount of Achilles tendonitis and even Achilles tendon ruptures with those type shoes.
Got it. All right. Thank you very much. I want to thank all the faculty for a great series of presentations, Dr. Halpern for his introduction, and most of all, the audience for joining us, as well as a series of great questions. We'll look forward to seeing you at the next webinar. Have a great day and stay safe.